primary and secondary. Okay. Primary headaches are basically four: tension headaches, migraine, cluster headaches, and this other group called trigeminal autonomic cephalgia, or TAC. But I want you to add this category, relatively new, and it is called under primary, hypnic headache. It's rare. It's a REM sleep associated primary headache seen in the elderly. We'll talk more about it. Okay, just I put on the side note, if somebody asks you what are the primary headaches, don't say hypnic headache first. Right? Say tension, migraine, cluster, trigeminal autonomic cephalgia, then say hypnic. Because it's rare. Many people don't even know about it. 90% of the headaches you will see in practice are going to be primary. About 10% of them will be secondary. And secondary has a lot longer process. But the good thing about secondary is that the causes of secondary headaches tend to be very specific, and you almost always will not miss it. Okay? So under secondary, we have trigeminal neuralgia, we have vascular disorders like temporal arthritis, internal carotid artery dissection, reversible cerebral vasoconstriction. Then you have this cervicogenic headaches, comes from arthritis of the cervical spine, right? And it can give you headaches. Then you have medication overuse. When you take pain medication, especially for headaches, for more than 15 days per month, you are likely to have medication overuse headaches. Okay? You understand that? Okay. And then caffeine withdrawal headaches. You drink coffee every day, and you don't have, for some reason, you have no access to coffee, you will develop a headache. Okay? Caffeine withdrawal headaches. Then you have all these metabolic headaches from metabolic conditions like hypoglycemia, hypoxia, hypocapnia, and stuff like that. They have headaches from infections, good kind of infections, sinusitis, meningitis, encephalitis. You can get headaches from cavernous sinus thrombosis. I told you the story of cavernous sinus thrombosis before, right? Good. Then intracranial hemorrhage, like epidural, subdural, subarachnoid. And then remember, subarachnoid hemorrhage can be spontaneous or induced. Spontaneous means there is no baseline abnormality. Induced means there was some aneurysm that ruptured, or AVM, arteriovenous malformation, or it could in fact be intracerebral hemorrhage. Okay? And then you have traumatic brain injury, right? You have intracranial hypotension. Intracranial hypotension. That is when CSF is leaking from the central nervous system. And then you have intracranial hypertension, also known as pseudotumor cerebri. And then you have brain tumor. You see, long list, right? But you will be able to recognize them as we go forward, because I'll tell you, you realize that each of these secondary conditions tell you a story. The patient will come with a story that you will recognize. Okay? So let's start with and then what is even bad is that even though I give it to you as primary and secondary, that is not exclusive classification. There is significant overlaps. There is nothing that stops a patient with migraine from developing tension headache. Okay? And there is nothing that stops somebody with cervicogenic headache from developing migraine. You understand what I'm saying? Mm-hmm. So the classification are not exclusive. So don't be rigid. Just talk to the patient, right? And take a good history. Almost always, you will be able to tell them apart. Okay? So let's start with tension headache. This is exactly how it feels, right? Tension headache presents with a non-pulsating band-like pressure, usually on both sides of the head. It's non-pulsating. Typically, the patient describes this as, my head feels light. Okay, it's non-pulsating. What are the things that will cause it? Look at it. It's stress,
PH cool.
fear, worry, not sleeping, bills, paying your bills, you're paying too much.
It's me, man.
Right? You get this, and it feels just like that. It's like there's a band around your head. And people with tension headache, they have a typical body habitus. They always go like this. See? Have you seen people do that? Yeah. That is the habitus of somebody having a tension headache. Okay? Just remember that it is non-pulsating. No, you know how you say you have my head is pounding?
Oh, like
Throbbing.
yeah.
Boom, boom, yeah. They don't feel that. It's a non-pulsating. Okay? So it's not like a throbbing head. Okay? That's all there is about tension headache. Right? And many of them are just like this. One slide description, and you will know it when you see it. Migraine, yeah. You know, migraine, we talk about migraine as a unilateral headache, comes with an aura and 4 stages. That typically is not what you see in practice. That classic migraine that everybody talks about is seen only 1 in 5 patients. 1 in 5 patients will present with a prodrome where they will be able to tell you 2 hours to 2 days before they get an attack. They know an attack is coming. They have this dysphoria, something in their mood that will change. They can tell you, I'm about to have an attack. And about a minute before the attack, they will get a neurologic disturbance that we often call an aura. It could be a visual field defect, like a scintillating scotoma. Did I talk to you about scintillating scotomas? Okay. A scintillating scotoma is like lightning. The patient will just see flashes of light, but it's not like a flash. It comes on like a flash, stays, and blurs the patient's vision in the, okay, so somebody with a scotoma might see a lighting like this, right? And that lighting might be across their visual field. For as long as that light is there, they're not going to be able to see anything in that field. They will see all around it. So it behaves like a blind spot. But instead of seeing nothing, you see light. Okay? So it's called a scintillating scotoma. Or it might be a paresthesia. But definitely about a minute or an hour before the migraine attack, there is a neurologic disturbance called an aura. And then the pain comes, which is the headache itself. And the typical classic migraine is unilateral, is pulsatile. Okay? It is often associated with nausea and vomiting. Photophobia. When people are having the classic migraine, they want to be in the dark room, turn off all the lights. They don't want to hear any sound because they are very sensitive to light and sound. And then after the attack is gone, which could be for 2 hours, 3 hours, 6 hours, sometimes it's 3 days, they go into the post room when they are recovering from the attack. This is the classic migraine. Most of the patients are not going to have classic migraine. They will have what is called a common migraine. And common migraine is basically migraine without the aura. So they have no aura, they only have these headaches and different components of it. Okay? There is no prodrome, there is no aura, they just have the headaches. So migraine without aura is your common migraine, and that is what 4 out of 5 patients you see in practice, that's what they will have. Now, there is a group called variant migraine. These are just all kind of migraines that we know exist. And you really have to have a very high index of suspicion for you to diagnose them. There is one called aura with atypical headache. So you have somebody, they tell you they have migraine, they tell you they know when their migraine is going to come, and then they get the headache, and it's a bilateral headache. Even though the patient has an aura, the headache is bilateral. That is how variant migraine could present. And sometimes your patient will get an aura without a headache. So the patient will come to you, I see flashing of lights, flashes of light that interfere with my vision when I'm driving at the end of my walk home. And they well, okay, and what else happened? Say nothing, I just see these flashes of light. You don't get any headaches? No. That is exactly how acephalgic migraine presents. They get the aura, but the headaches never come through, right? And then you have hemiplegic migraine. What we believe about migraine is that migraine is due to a neurological disturbance. A neurological disturbance in the cerebral blood vessels. We believe that the pathophysiology of migraine is such that severe vasoconstriction is followed by severe vasodilatation. That is what we believe. It's a transient alteration in the tone of the cerebral blood vessels. Now, if you get the vasoconstriction and that vasoconstriction is severe enough, you can actually end up with a stroke. Okay? When that vasoconstriction that is preceding the vasodilatation in the migraine is severe enough, you can end up with a stroke. And that is what is called hemiplegic migraine. It could be sporadic, sometimes they run in families. And when that vasoconstriction occurs in the brainstem, the patient will present with brainstem dysfunction, and you are masters of those now. Vestibular dysfunction, vulvar dysfunction, ophthalmoplegia. When patients present with any of those that you will recognize as brainstem dysfunction, you say your patient has migraine with brainstem aura, or basilar migraine. You got that? Okay. And then you have retinal migraine, where the vasoconstriction is primarily in the retinal blood vessels. Vasoconstrict cuts off the blood supply from the retina, the patient goes blind temporarily and they regain. Okay. The most difficult thing to tell apart here is hemiplegic migraine and TIAs. How would you tell them apart? TIA patients typically don't get headaches. Whenever your patient has TIA and they have headaches, whenever your patient gets TIA and they have headaches, you should think, are you dealing with hemiplegic migraine? Okay? So if I give you a 26-year-old female, no significant past medical history, presenting with right side weakness that disappears within 4 hours, and I say, okay, is that a TIA or is that an hemiplegic migraine? What is it? Hemiplegic migraine. Why would it be a hemiplegic migraine? Because she's young, no hypertension, no diabetes. You don't get TIA without all of those factors, right? But you can get hemiplegic migraine without any of those. Are we good? Good. So you see, all of this is just information. All I need to tell you here is tell you a story, and you will come to the right diagnosis. You don't even need to think about it. You just need to know it does exist, and this is how it presents. Okay? So that's all about migraine. Any question on migraine? Mm-hmm. Good. Let's talk about cluster headache. Cluster headache is called cluster headache because it occurs in repeated excruciating attacks. So somebody with cluster headaches will have these big, multiple paroxysms of these headaches, typically lasting anywhere from 15 minutes to 3 hours. How do you know you're dealing with cluster? It's a unilateral periorbital ache that is associated with at least one of the following on the same side of the headache. So it's a one-sided headache. It looks like migraine, but the difference is that it is usually around the eye. So whereas tension headache patients go like this, cluster headache patients go like this. And when you say take off your hand from your eyes, you see, look at them, they may have ptosis, partial ptosis, they may have pupillary constriction, their conjunctiva may be red, they may tear, they may have rhinorrhea, their face may be swollen, and they may have sweating on that side of the face only. Cluster headache is what everybody talks about. But cluster headache is not alone. Cluster headache is part of a bigger group of headaches that are known as trigeminal autonomic hepalgias, TACs. Okay? We believe they are actually, don't write this down, don't record it. The best way I look at this TACs is like they are neuronal seizures, right? Because see what it is. We know that when people have these trigeminal autonomic hepalgias, they have activation of the autonomic nervous system fibers carrying the fifth cranial nerve. So those fibers just start firing. Like if they were motor fibers, the patient would have been seizing. If they were sensory fibers, the patient would have been having paresthesia. But because they are autonomic fibers, the patient presents differently. Most commonly, they present with cluster headaches. In cluster headache, we know that the inappropriate activation occurs in all the three branches of trigeminal nerve. The ophthalmic, the mandible, and the maxillary branch. But there are times the activation does not involve all the three branches of the trigeminal nerve. Right? It may involve just the ophthalmic branch. So you have a patient having a short-lasting, unilateral, neuralgiform, meaning it's coming from the nervous tissue, headaches with conjunctival injection and tearing, and they call it SUMP. Okay? Short-lasting, unilateral, neuralgiform headache with conjunctival injection and tearing, SUMP. Again, it's a variant of cluster headache that is limited only to the ophthalmic branch of the nerve. And then there is another variant called hemicrania, also limited to the ophthalmic branch. But this time, it occurs in two ways. There are times it will be paroxysmal, and there are times it will be continuous. When it is paroxysmal, it's called paroxysmal hemicrania. When it is continuous, it is called hemicrania continua. Okay? All you need to know about SUMP and hemicrania is that they are variants of cluster headaches. Okay? Resulting from activation of the autonomic nervous fibers carried in the trigeminal nerve. I found this table did a good job of comparing cluster headache with paroxysmal hemicrania and SUMP. The only thing I want you to pay attention to here is look at the attack frequency. When people have cluster headache, they get one attack every day or every other day. Of 8 attacks per day, right? When they have paroxysmal hemicrania, they can have up to 1 to 40 attacks in one day. When they have SUMP, look at this, up to 3 to 200 attacks in a day. That is the most significant difference between them, right? The frequency, okay? So when you see cluster headache with an abnormal frequency, that is your clue right there, that this may not be trigeminal neuralgia. This may not be cluster headache. This could in fact be a TAC. Trigeminal autonomic hepalgia. Pay attention to them. Whenever the patient presents and it looks like cluster headache, it smells like cluster headaches, it feels like cluster headaches, but the frequency is absurd. They're having up to 3 dozen attacks a day or hundreds of attacks in one day. That is no longer cluster headache. That could, in fact, be a TAC. Why does it matter? It doesn't matter because if you can diagnose TAC, instead of giving your patient oxygen and all this expensive medication for cluster headache, if it is proximal hemicrania, they will respond better to the medicine. And if it is a sunk, you're better off with namodipine. And these are anticonvulsants. You see where my idea of this being some kind of precision is coming from because of the way to treat them, especially in their severest form. Okay? Cluster headache, we treat symptomatically, right? With symptomatically just like we treat migraine. But what I want you to never forget about cluster headache, see what we use to prevent it. Prophylactic treatment is by verapamil. Okay, very important. Okay? Are you with me on this one? Mm-hmm. Do not get, listen to me, stop writing, listen to this. Do not get cluster headache and tau, trigeminal autonomic hepalgia, mixed up with trigeminal neuralgia. Okay? You see, trigeminal autonomic hepalgia include cluster headache and SOMT and the paroxysmal hemicrania. All of them are due to activation of the autonomic fibers that are carried in the trigeminal nerve. Trigeminal neuralgia, on the other hand, is like a seizure, it's an activation of the regular sensory fibers carried in the trigeminal nerve. Okay? So it's the same nerve, but different components of the same nerve. Okay? Don't get them confused. Because I'm going to talk now about trigeminal neuralgia.
A question.
Yes?
So that is like, if they're diagnosing somebody, they would be specific to the actual type of attack they have?
Oh yeah. Most of the time they will give you paint a picture of the attack for you.
Okay.
Just have to decide whether it's a SOMT or proximal hemicrania continuum or it's a cluster. Yeah. I just don't want you, they may ask you it's related to this particular nerve and they may put the TAC there or they put trigeminal neuralgia there, right? I just want you to know that they both have a lot to do in the pathophysiology, the trigeminal nerve, but different fibers of it. Okay? Trigeminal neuralgia is actually a nerve, is a neuralgiform pain of the regular sensory fibers that are carried in the trigeminal nerve. So how does it present? Trigeminal neuralgia presents with pain, shooting pain in the 3 branches of the trigeminal nerve. So the patient with trigeminal neuralgia will come to you telling you they have a shooting pain that is going toward the eyes, their nose, and their mouth. That is a typical trigeminal nerve pain. It has nothing to do with the autonomic fibers. Trigeminal neuralgia patients do not have redness. Their nose don't run on that side. They don't tear on that side. They just have pain. You understand what I'm saying? This is so important in differential diagnosing. Okay? So typical, you have intermittent, sudden, severe shooting pain on one side of the face. Again, like cluster headache, like SOMT, it is usually on one side of the face. But the difference is, in cluster headache, it's around the eye. Whereas in trigeminal neuralgia, it's shooting from the ear toward the eyes, toward the nose, and toward the mouth. In cluster, there will be all those autonomic signs, like ptosis, like meiosis, like sweating. You don't find any of those in patients with trigeminal neuralgia. Okay? What causes trigeminal neuralgia? Anytime you see somebody with trigeminal neuralgia, most of the time you will not find anything. But as a good clinician, you will make sure you exclude everything written under nerve irritation. You want to rule out a vascular disorder, so you will do a CT scan or an MRI to make sure you're not missing actually an MRA, magnetic resonance angiography, because you want to make sure you're not missing an aneurysm or an arteriovenous malformation that is irritating the nerve. Okay? You want to make sure you don't miss a CPA tumor. What is a CPA tumor? A tumor that sits at the cerebropontine angle. What would you see in a patient? There is one question in my exam that I'm waiting for the person that will get it correctly. They will keep telling me to change it. I'm like, I'm not going to change it. I'm going to tell you that answer now. Hopefully you will be the first class to get me the right answer. What would you see in a patient with a CPA tumor who is presenting with trigeminal neuralgia? What will clue you in that this is no ordinary trigeminal neuralgia? Huh?
The lack of consciousness because of particular
CPA tumor, think about it as a small tumor. Just think about it. Say it again. Is that correct? Visual disturbance. Why would there visual disturbance? They have to have problem with the optic or oculomotor. Is that in the pons?
No.
It's along the same line, but can somebody do better? Say it again.
There's 5 to 8 that are.
Thank you. So 5, 6, 7, 8 are from the pons, right? So if somebody has a CPA angle tumor, they will come to you with, they may come to you with trigeminal neuralgia, or they will come to you with nerve deafness. So whenever you see nerve deafness in somebody with trigeminal neuralgia, you're not dealing with trigeminal neuralgia, you're dealing with a CPA tumor, because both the 5th and the 8th nerve come off from the pons. And if there's a tumor there that is big enough, it can clip both of them and cause trigeminal neuralgia and cause nerve deafness. Okay? I'm sure you will get it now because
What do you mean by nerve deafness?
nerve deafness. How many kind of deafness?
Because of the nerve ache.
Oh, you meant like nerve deafness. Sorry.
Is that what I've been saying?
I thought you were
I'm
talking
going to
about
say it
like,
in African language.
no, I was talking about like the
Nerve
nerve.
deafness.
Actual
Nerve deafness of nerve origin. Sensory neural deafness. Is that it? Yeah. Sensory neural deafness. Is that a better term? Facial palsy, if the nerve is big enough, it could also be there. They can have a lower motor neuron facial palsy. Yes. So these are things that will clue you in to look for a CPA tumor. Lower motor neuron facial palsy, sensory neural deafness, trigeminal neuralgia. All of these together will clue you into thinking this patient may have no ordinary trigeminal neuralgia, there might be a tumor there. Okay? Thank you, Ali, for I need to include patient epilepsy. So now, post-herpetic neuralgia and multiple sclerosis, you must look for all these things. How do you look for them? Do a thorough physical examination. Okay? Because if somebody comes to you with trigeminal neuralgia and you're so caught up with the pain, and you want to treat the pain, you don't take your time to examine them for hearing, you will miss the nerve deafness and you will miss a tumor. You have your patient who is having a brain tumor in the medicine until it's too late. And the autopsy will show that you are taking care of the patient for 6 years and you did not diagnose brain cancer. Wow. That will not be good for you. All right? Again, I want you to remember there are no autonomic manifestations in trigeminal neuralgia. That's what I started. Those autonomic manifestations are the ones we talk about. Those is the tearing, the runny nose, and all that. Everybody clear with that? Excellent. Now, remember cluster headache? He has his own unusual equivalent we call TAC, right? Trigeminal autonomic hypalgia. Trigeminal neuralgia has its own unusual associate. It's called nominal headache. Nominal headache is actually a trigeminal neuralgia that is localized to a point area of the scalp. So somebody will come to you, they say, it hurts right here. And when you touch it, they jump. But you don't see anything. It's like a point area, usually in the scalp, extremely tender. You can't see anything. You do x-ray, you examine it, there is nothing there. But they have that pain in the scalp. That is called nominal headache. It's an unusual, this is the journal that it was described. And the reason they described it was that they reported a patient that came in with a typical trigeminal neuralgia. And then as they started thinking and treating it, the trigeminal neuralgia went away. But then the patient developed this painful patch. It's a coin-sized patch on the scalp that stayed tender throughout. Okay? And if you did not know that that patient had trigeminal neuralgia, you'll be wondering what that is. So that is what nominal headache is. Okay? It's localized, a coin-sized localized area of tenderness in the scalp. Okay? Now, I can skip this slide because you know everything about temporal arthritis, right? Temporal arthritis is giant cell arthritis of the temporal artery. It's also known as Hutton's disease, right? Remember that? And it's an inflammation of the vasa vasorum of the light and medium blood vessels. For some reason, in Hutton's disease, he has a particular predilection for branches of the external carotid arteries. And these are the branches that could be affected by temporal arthritis. How does it present? There is a female, over the age of 50, they have unilateral temporal headache. Do you see how many kind of headaches could be one-sided? It's not all migraine. You have to calm down, take a good history, and know what to do with it, right? It is associated with polymyalgia rheumatica. Remember that. Tender temporal artery. When you touch the temporal artery, it's painful in these patients. Your hallmark is elevated erythrocyte sedimentation rate. How do you treat it? Steroids. If you misdiagnose it, you'll be giving them sumatriptan. When you should be giving the patient steroids. You know the cost difference between sumatriptan and steroids? It's like 100-fold. Are we good? And of course, you know that you have to diagnose it by biopsy. But nobody does biopsy. We give it, once you diagnose, you treat it. Why would you go to biopsy? You already treated the patient. The point is to make the diagnosis. If you make the diagnosis and you give the steroid and the patient feels better, why do you need a biopsy? The only time you need a biopsy is it looks like temporal arthritis, feels like it, you started treating it, the patient is not getting better. Then you find it, you go to biopsy. Okay? Are you with me? Excellent. What the? Justin, what's up with this? This thing is possessed, man. Oh.
Dr. Martin, let me ask you a question.
Sure.
For cluster headache, is there a preference for treatment, whether you use oxygen first or
Whatever works. Now, there is this new thing here. It's not really new. We just now found it out. Internal carotid artery dissection. You remember aortic dissection? Imagine having a dissection in the internal carotid artery. the first thing you'll ask me, who gets that? Sometimes anybody can get it. It could be spontaneous. Other times it could be induced by minor trauma in somebody with migraine, hypertension, polycystic kidneys, and connective tissue disorders. Remember I told you that migraine is an instability in the tone of the cerebral blood vessels. Severe vasoconstriction followed by severe vasodilatation. That trauma of constriction and vasodilatation can actually rip the intima of internal carotid and initiate this dissection in migraine. Of course, it is easy to understand why it will happen in hypertension. It is also easy to understand why it will happen in connective tissue disorders and polycystic kidneys, because they have connective tissue abnormality, right? How does it present? When you have internal carotid artery dissection, you get orbital pain. Then you get Horner's syndrome. You see how complicated things are becoming now? Because remember, cluster headache is basically really orbital pain and autonomic manifestation. Well, Horner's syndrome is an autonomic manifestation, right? So how then do you tell internal carotid artery dissection from cluster? No anhidrosis. That's sweating. That you get with Horner's syndrome is not here. So if there are two conditions that you might indeed get confused, is internal carotid artery dissection and cluster headache. Because they both have periodical pain and they have autonomic dysfunction, right? But one thing that tells internal carotid artery dissection apart from cluster is neurologic deficit, because remember, it's a dissection. So they are forming clot, and they will flip those clots sometimes, and that will give them a stroke. Okay, you understand that? Okay. And sometimes, unfortunately, that stroke can happen in the eye, so they get retinal ischemia. And this is just telling you again what this picture is exactly what we had when we talked about aortic dissection. Only this time I limited it to internal carotid artery. Okay? So, how would you suspect internal carotid artery? Say you have somebody, a patient, who develops severe periodical pain. You examine them. They have ptosis, the pupil is constricted, but nothing else. There is no tearing, there is no runny nose, there is no redness. That right there is pointing away from cluster headache, right? Now, when you now examine the patient closely, and your patient is young, under the age of 50, you're more likely dealing with internal carotid artery dissection. Okay? Now some examples, hopefully we'll get there before this time. There is a lot of things you have to learn to remember by association. Remember how we associated tax with cluster, right? And we associated nominal headaches with trigeminal neuralgia. You have to learn to associate vertebral artery dissection with internal carotid artery dissection, because it's exactly the same process. The only difference is this one is happening in the posterior circulation, while the other one is happening in the anterior circulation. That's it. Of course, because it is happening in the posterior circulation, the patient will present with brainstem dysfunction, dysarthria, dysphagia, dysynergia. Okay, remember those? Are you with me?
Yeah.
Okay. One of the causes of headache that also you should remember is reversible cerebral vasoconstriction syndrome. Remember, migraine is vasoconstriction followed by vasodilatation. The difference between migraine and reversible cerebral vasoconstriction is that this one can go on for up to 3 months. And when you repeat the MRA or the CTA, that is CT angio, MR, magnetic resonance angiography, you will actually see it disappear. It will vanish. The reason this is not in many books is because this seems to be the pathophysiology of hemiplegic migraine. Remember I told you about hemiplegic migraine when I said that if there's a constriction occurs in some strategic areas, the patient will actually end up with neurodeficits. There are some people that believe that this in fact is hemiplegic migraine, but I don't think it is. Like other groups that believe it is not. I belong in that other group. The reason I say it is not is because there is something about reversible cerebral vasoconstriction syndrome in such a way that there is autonomic disturbance of course sympathetic hyperactivity that causes vasoconstriction, increases the blood pressure, and creates this TCH, thunderclap kind of headache. That is the stage where blood rushes to the brain as a result of elevated blood pressure. But along with that, there is endothelial dysfunction. You don't find endothelial dysfunction in migraine. Migraine is all about vasoconstriction and vasodilatation. The endothelium is intact in migraine. In reversible cerebral vasoconstriction, you have endothelial dysfunction. So you have headache, you get this vasoconstriction, you have this area of ischemia, severe vasoconstriction, and then you end up with this posterior reversible encephalopathy syndrome. Again, these are just neuroscience. These are the triggers, and these are some of the medications that can actually precipitate it. Now, before you start freaking out, I don't expect you to memorize anything here. The only reason I'm giving you this is because of what I said here. Constriction of intracranial blood vessels that normalize within 3 months. So it will give you a symptomatic vasoconstriction of the cerebral blood vessels. You will see changes in the MRA, and the patient will completely recover within 3 months. That's one way to know about that. Now it's downslope from here. Sinusitis can give you headaches. You know what a sinus is? We talked about this in immunology, right? Actually, you've seen this slide before. That's good. And paranasal echo, rhinorrhea, sinus congestion, and posterior nasal drip. That is how you know you're dealing with sinusitis. But more importantly, if you palpate over the sinus, you will elicit tenderness. That is what fools you in most of the time. Okay? Because somebody could have chronic sinusitis that is not causing the headache. Why do you get headache in sinusitis? When the sinus is congested. So if the sinus is draining and it's not congested, even though the patient will have history of sinusitis, the sinusitis will not cause headache. It is when the sinuses are filled and they are not able to drain that it causes headache. So I don't want you to misdiagnose tension or anything as sinus headache. More importantly, pay attention to that rhinorrhea, nasal congestion, and posterior nasal drip. That's how you diagnose sinusitis. You know about this, you've seen this slide before, cavernous sinus thrombosis. How do you diagnose cavernous sinus thrombosis? Deadly disease. It's a complication of central sinus or facial infection. The infection spread through the vein into the cavernous sinus. What do you have in the cavernous sinus? You have cranial nerves 3, 4, 5, and 6 in there. So your patient presents with stenosis, multiple cranial nerve deficits. You see the problem on the CT scan on the MRI. All these nerves are going to be affected. This is actually a surgical emergency. You have to admit this patient, begin intravenous antibiotics, give them anticoagulation, and get surgical consult for drainage. Okay, so I just put that there to complete the record. They all talked about meningitis, right? Right, you know about meningitis. You know it can cause headache, right? And you know about panic stem and frozen skin, right? Good, that is how you diagnose meningitis. How about encephalitis? Inflammation of the brain. What is encephalitis? Encephalitis is just inflammation of the cerebrum. Some people call it cerebritis actually, but encephalitis or encephalitis is better, right? What is it? It looks like delirium. The only difference between encephalitis and delirium is headaches with fever. Okay? A delirious patient can have fever if infection is causing the delirium, right? And they can have headache if it's a systemic infection. So technically speaking, it is almost impossible for you to tell encephalitis from delirium. Okay? Almost impossible. I have to give you enough information to tell you this is encephalitis versus delirium. Here is an attempt by somebody to actually differentiate between encephalopathy and encephalitis. What is encephalopathy or encephalopathy? How would you prefer for me to say it? Encephalopathy? Okay. Encephalopathy is usually a metabolic-based pathology of the brain. So if somebody has what looks like delirium as a result of liver failure, you call that hepatic encephalopathy, right? So if somebody has delirium as a result of, say, renal failure, you call that renal encephalopathy, right? But when it is due to infection, we call it encephalitis, right? And here is an attempt to try to differentiate the infectious origin from metabolic origin. So what this table is telling you, you notice that the difference really here, fever, yes, in infection, headache, more likely in infection, depressed mental status, you could find in both. Focal neurologic deficits, more likely in encephalitis, especially when there is a pause or suppuration now, abscess developing. Seizures, you can have it in both. But the real difference is, look, leukocytosis is very uncommon in encephalopathy because it is not an infection. Okay? So, encephalitis is headache with fever and delirium. It will give you headaches. But you know what? I put this here just to complete the books. Invariably, encephalitis is not what you will deal with in the clinic. All your patients with encephalitis are in the hospital. Okay? And headache is the least of their problem. They have bigger issues that you're going to be dealing with. Okay? Now, this is important. Another cause for headache is intracranial hematomas. Intracranial hematomas. When people bleed inside their brain, they could bleed above the dura, below the dura, or inside the brain. And it is not random where they bleed. If you crack your skull and you bleed, that bleed is going to be above the dura. It will be an epidural hematoma. It will be an arterial bleed. And it looks a certain way on CT scan. If on the other hand, you rupture a vein, a dural vein, you will bleed under the dura. We call that subdural hematoma. That is usually a venous bleed. Look at the difference between the way they present. Epidural hematoma and subdural hematoma, they both present with headaches. But look at the important difference. Because of the severity of the injury, usually associated with epidural hematoma, they often suffer an associated cerebral concussion. That cerebral concussion will result into an initial loss of consciousness, from which the patient will rapidly recover and will feel like they're okay now. Send me home, I can go home, doc. You don't send me home, I'm going to sign out AMA. And once they leave, in that process where they have regained consciousness, that we call a lucid interval, because that consciousness is going to last. As they bleed and bleed and bleed over time, they increase their intracranial pressure and they lose consciousness again. This time because of intracranial hypertension, not from cerebral concussion. So one big difference between epidural hematoma and subdural hematoma is lucid interval. An interval of consciousness when patient feels they're fine, they can go home, everything is fine. On the other hand, subdural hematoma is usually seen in old people when they fall. There was a male in the city one time who fell in the bathtub and thought he was okay. And 6 hours later, he was found unconscious. That is a subdural hematoma. They lose consciousness once and it's progressive until you take out the hematoma. Okay? They don't experience lucid interval, nothing. They get the injury, many hours later, they develop, they lose consciousness. Are you with me now? Okay, good. See how epidural hematoma looks on CT scan. See that biconcave? There is a reason it looks biconcave. The reason it looks biconcave is because it is an epidural hematoma. And the reason it looks biconcave is because the bleeding does not cross suture lines. Because the dura and the periosteum, they get connected at the sutures. So there is no way for the blood to cross the suture. This is I put this picture here to show you the double connection of the dura to the periosteum in the suture space. In the suture space, the dura is connected to the periosteum of the skull. So the bleeding cannot cross the suture. And because the bleeding cannot cross the suture, it does not extend across along the skull, rather it spreads out. That's what gives it the biconcave appearance you see in the CT scan. Did you get that?
Dr. Marcos, are you using biconcave and biconvex in one mostly? You said biconvex and
Biconcave, biconvex. It looks bulging on both sides instead of a crescent. I thought, what if this is supposed to be biconvex? Right? Yeah, you know what I'm saying? Yeah, biconvex. Yeah, it's supposed to be biconvex. Convex is the one that boils down. Concave is the one that can hold water. All right. The third type of intracranial bleed, no, second, is subarachnoid hemorrhage. That is bleeding into this subarachnoid space. And because it is usually associated with meningeal irritation, it presents like meningitis with Koenig sign and Brzezinski sign and headaches. The only difference, no fever. Okay? You talked about subarachnoid hemorrhage before, right? Okay. Next statement, vomiting, photophobia, delirium, loss of consciousness. And they have this headache called thunderclap headaches, followed by meningeal irritation. Okay? Now, the last type of intracranial hemorrhage is bleeding inside the brain. How do you know when somebody has bled inside their brain? They will have neurodeficit. They will be paralyzed on one side or somewhere, somehow. Okay? Very important. And how do people believe? What is the pathophysiology of intracerebral hemorrhage? Hypertension is one of them. Okay? And then all kind of aneurysm, malformation, and stuff like that can rupture and result in a bleed. You see that before? Good. So that is all about intracranial hemorrhage as a cause of headache. We talked about epidural, convex, subdural, crescent shape, subarachnoid, thunderclap with meningeal irritation, positive Koenig and Brzezinski, right? Talk about intracerebral, headache with neurodeficit, headaches, vomiting, right? Now moving on to traumatic brain injury. This is just basically somebody hit their head. There are 3 types of injury. Kelly talked about this, right? Concussion, contusion. Exactly. Okay. So when you hit your head, you can bruise your brain and you will lose consciousness, but you regain consciousness nearly within 15 minutes. But if it is severe, where you are now disrupting fibers, that is not contusion. It's a more severe type of traumatic brain injury. And then there's a third group we used to call laceration, but now it's called cerebral edema. Swelling from inflammatory response to the injury. Why is this important? Because this happens a lot. If you happen to take a job in the school, and kids are playing soccer or playing whatever they're playing, and somebody hit their head and passed out, and then they bring the kid to you, they can this kid go back to the game because without him, the team will lose. You're under this pressure. You need to have a good idea of how to make decisions in such situations. If the kid was out for less than 15 minutes, that is the least injury, you can go back. But if the kid was out for more than 15 minutes and he still does not remember what happened, that is not the kid you want to send back. If the kid is unconscious when they brought the kid to you, they're not going to trust. So unconscious, you can't go back again. Right? So that's just important that you know about traumatic brain injury and how to deal with them. Very important that you pay attention to the duration of loss of consciousness. Anytime somebody suffers severe traumatic brain injury, they are likely to fracture the base of their skull. That is the height of traumatic brain injury. Fracture of the base of the skull. You need to know how to know when somebody may have fractured the base of the skull, because there are flowing specific clinical signs that can let you know. Whenever there is a fracture at the base of the skull, you will see blood behind the eardrum. Okay? That is called hemotympanoid. You will see, you know the way you talk about Great Tunnel, the way the blood dissects the surface tissue, that same blood will dissect the skin and appear behind the ear of the patient. It's called battle sign. And it will appear on the eyelid like this. Because the tarsal plate is so close to the skin, you will not be able to dissect the tarsal plate. So they have these rhabdomyolysis. So whenever you read any questions, and they're talking about rhabdomyolysis, battle sign, or hemotympanoid, basically what they're telling you is that this person has fractured the base of their skull. Who can do that? Old people when they fall. So whenever you see this evidence of basal skull fractures, you must do a CT scan, right? So this list over here is when must you do a CT scan in somebody with traumatic brain injury. So somebody, they say, oh, he was hit on the head by his wife with a baseball bat. And then you're now trying to figure out, does he need a CT scan? No? He's more than 60 years. If he had a seizure, if he's vomiting, if he's having headaches, if he was an anticoagulant, like epixiline, if he's making watery fluid from his nose, that is CSF running down his nose, okay? If he has any neurologic deficit, if his Glasgow coma scale is less than 15, or if he fell from more than 3 feet height, or if he was ejected from a vehicle with an accident, or he was hit by a high-speed vehicle. These are times that you must do CT scan of the head. But invariably, when you have all this in somebody with traumatic brain injury, you should do a CT scan. But I tell you, this list here is not standard. So it's unlikely anybody will ask you a question about the list here. They're more likely to test you on this. So this is for you in practice. This is for you in preparation for your exam. You got that? All right.
So Dr. Martin, just to clarify, so after seeing the vital signs, we still order the CT?
Yes, because that's a business called fracture. Vital sign racking or immobility. Brain tumor. That is it. Everybody with a headache comes to your clinic and they think they have a brain tumor. That's just the case. How do you convince them that it's just a headache? It's not a brain tumor. Headache due to brain tumor has some specific signs. Headache with vomiting and neurodeficit should make you think about a tumor. Headache with vomiting and neurodeficit. Look at all those things over there. There are some kind of neurodeficit, seizures, cognitive decline, speech problem, hearing problem. Anytime there is a neurologic deficit in somebody with a headache, especially when it's been going on for a while, like say maybe it's been going on for like 3 months, they're dealing with a tumor. If it's happening severely, suddenly, they're probably dealing with a bleed. Are you with me? Mm-hmm. Excellent. Okay. All right. We're almost there. Part of the list we talked about earlier was intracranial hypertension. How do you get intracranial hypertension? Anytime you're losing cerebrospinal fluid, you will develop intracranial hypotension. How do you lose intracranial? How do you lose CSF? Because you rupture the neuro, right? And CSF can leak through your nose. It can also leak through your ears. More often than not, it leaks through your nose as a clear, watery liquid. Who gets it? Well, you know, when you rupture your dura in your head, you will leak CSF openly. But supposing you rupture the dura in the spine, say somebody has spinal arthritis and they have osteophytes, and one of the osteophytes punctured the hip and they leak CSF. You won't see that. But your patient will come to you with intracranial hypertension. How do you know when somebody has intracranial hypertension? Patients with intracranial hypotension have a special headache called orthostatic headache. You know we talk about orthostatic hypotension? Orthostatic headache is the headache patient gets every time they get up from bed. They develop headache. When they go back to bed, the headache goes away. They get up, they get a headache. They go back to bed, lying flat, the headache goes away. The headaches that are aggravated by upright posture or when they strain, they are known as orthostatic headache. Okay, and how do you, when you suspect it, how do you diagnose it? Do a lumbar puncture, measure the opening pressure. They did that in diagnosis in the lab already, right? Yeah. You measure the opening pressure. You see what is the normal opening pressure for CSF? 8 to 15. Is that CM of water? Okay. It will be low. It will be like 5-4. You know you have a low opening pressure. That means this is orthostatic headache. Okay? It's interesting. How do you treat it? You seal the leak. How do you seal the leak? Use the patient's blood. You seal the leak. It's called blood patch. Okay? We'll talk about that in a little bit later. I think this is my last type of headache. This is idiopathic intracranial hypertension. It's also known as pseudotumor cerebri. I know you're tired and we're talking about a lot of concepts. I'm getting close, I'm wrapping up, so don't fall asleep. This is important. Pseudotumor cerebri is called pseudotumor cerebri because when this condition was first discovered, we thought that patients have tumor in their brain. But we later found out that no, they don't have tumor in their brain. We still don't know what causes it. But generally speaking, it is seen in young, obese women of childbearing age. They come to you with headaches. And the headaches would have been on for a long time. And because it's been on for a long time, they have visual disturbances. And there is a reason they lose vision. They begin to lose, they also hear noises in their head. And most of the time they have vascular noises. You know how we talked about tinnitus is subjective and objective? Okay. Patients with pseudotumor cerebri, they have this sensitivity, they can pick up vascular sounds in their head, right? They have headaches. But in exam, how would you pick this out? Usually it's a young, obese woman of childbearing age. They will have been on oral contraceptives for a while. Okay? Young, obese, childbearing age on oral contraceptives, or sometimes supplements. That's what pulls you in. It is usually due to excessive formation of CSF. And you remember the basic anion in CSF is bicarbonate. So that is why in treating it, we always give patients Diamox. You know what Diamox is, right? Acetylsodiamide. It inhibits carbonic anhydrase. So it stops the formation of bicarb. And if you don't form bicarb, there is nothing to hold the water in the CSF. So the CSF will be working. Okay. Good. I'm done. About causes. So you survive. But remember, it's not every time that somebody has a pain in their head that the problem is in the head. So there are differential diagnoses of headaches. You've seen this slide before, remember? Right. So when somebody has headache, think about eye problem, dental problem, think about jaw problem, ear problem. This can also present as headaches. We've seen this before, I'm not going to waste my time repeating it. Right? So let's move on. Now, when you see somebody with headache, clinically what you want to ask yourself is it the kind of headache I should worry about? Or is it the kind of headache I can just treat this patient and bring them back in 2 weeks? You have to risk stratify the patient. These are important clinical parameters to help you differentiate a low-risk headache from a high-risk headache. Somebody is less than 30 years old. They have a typical primary headache. Tension, migraine, cluster, back. It's a typical primary headache. They have a history of similar headache in the past. They have no significant past medical history, no hypertension, no diabetes, no cholesterol. Physical examination, especially neurological examination, is completely normal. You don't need anything else. Treat this symptomatically, the patient will be fine. But if you're dealing with somebody with over the age of 50, with systemic symptoms like fever, severe sudden onset, significant past medical history, hypertensive, diabetic, they have had stroke before, they are on anticoagulation, there is neuro deficit, you have to look deeper. So these are the characteristics of high risk headache and low risk headache. So you decide, okay, time I don't have, this thing is wasting. I think there's a conspiracy. All right, so once you decide what? Okay, right here. So once you decide somebody has a high risk or a low risk, I thought it's important for you to know that there are some things you will hear or you will see in exam that should make you think of some things. Anytime you hear in exam that somebody presents with a thunderclap headache, or whatever headache, say the worst headache of my life, you should always remember that they're asking you about subarachnoid hemorrhage or reversible cerebral vasoconstriction syndrome. And whenever they talk to you and they start using terms like stabbing pain, patient has stabbing pain, in other words, this sharp, severe shooting, sudden onset, they're asking you about trigeminal neuralgia, heart, and nominal headaches. Okay? I just wanted to make sure I say that to you. Cough headaches. Or somebody has cough headaches, you must remember that cough headaches, think about brain tumor all the time, or even intracranial hypotension. Okay? Good.
What's GI?
Oh, chiari malformation. Don't worry. Pediatrics will tell you it's an abnormality, it's a bony abnormality at the base of the skull that interferes with the development of the posterior part of the brain. Okay. But you do it in pediatrics. So once you risk stratify the patient and you have to now do the proper evaluation, you do all your routine tests, CT scan, and I put here that, remember when we're doing, I don't know what class we're doing, I told you, for any intracranial hemorrhage, you generally don't need contrast CT, just do non-contrast CT. But for tumors, you need contrast CT. Look the difference between these two CTs. The same patient, without contrast, with contrast. You see what difference contrast makes? You could have missed these tumors without a contrast. So when you're looking for tumors, you always need good contrast. How do you treat headaches? Well, now I'm going to treat all the headaches together. Okay? Remember, up until now, we just talked about the characteristics of them, right? So, how do you treat migraine? Mild to moderate, send them to get extra over the counter. That works. Moderate to severe, you give them the triptans. But remember, be careful with sumatriptan in people with atherosclerosis. Okay? How do you prevent? When do you need to prevent migraine? If somebody has more than 5 attacks of migraine per month, and the attack lasts more than 12 hours, that is the definition of disabling migraine. Okay? How do you prevent migraine? Beta blockers and anticonvulsants. The most popular one is topiramate. You can also use Galfabrex sodium. That is just dilantin, sophisticated dilantin. Topiramate is what most people use. Okay? Pay attention. Now, this is where I want everybody to wake up. Everything I've been talking about is important. This is the most important. Treatment, mild to moderate, excedrin, just combination NSAIDs. CBN, you give serotonin receptor agonist. They call triptans, sumatriptan, zomig, and all that stuff, right? How do you prevent it? First, you have to know when do I need to prevent it. More than 5 days a month attack, or an attack that lasts more than 12 hours. What medication can I use? Beta blocker or anticonvulsants? Most likely topiramate. And then you taper off after 12 months. How do you treat cluster headaches? Look, high flow oxygen. Again, triptan. See that? We don't know how to treat cluster headache. We just kind of hit and miss. Oxygen and triptans. But verapamil works very well to prevent it. Tension headaches, NSAIDs. Tension, give them TCA, antidepressant, right? Okay. Hypnic headaches. What are these hypnic headaches? Give them bedtime lithium. Why do we talk about these hypnic headaches? What are they really? The reason they're important is because they're seen in the elderly. They wake the patient up from sleep. And if you remember anything from the slide I showed you on that brain tumor causes headache that wake patient up from sleep. Okay, so if an elderly patient come to you and tell you they're having headache that wakes them up from sleep for years, don't be looking for brain tumor. You're probably dealing with hypnic headache, right? And if you give them bedtime lithium, they'll be just fine. Okay? How do you treat secondary headaches? Look at it, it's very simple. Trigeminal neuralgia, your medication is carbamazepine, Tegretol. Remember that. Don't ever miss that. It's cheap, it's available, it will help your patient. What is the problem? You have to monitor CBC and basic metabolic panel because it causes hyponatremia and agranulocytosis. And there are times carbamazepine will not work. You have to send the patient for surgery. You know what they do? They cut the nerve. That's what surgeons do. Okay. Temporal arthritis is already high-dose steroids. Vascular dissection, terrible disease, but see how we treat it. Just aspirin. Reversible vasoconstriction syndrome has something of blockers, like verapamil. Intracranial hypotension, indomethacin. If that does not work, if you draw a blood patch, right? So just put the patient blood into their own CSF canal, and their blood will clot. Once it gets exposed to that opening, you will see it by itself. Okay? Number headaches, gabapentin. Again, intracranial hemorrhage, we talked about this. There was a class, I keep remembering, we talked about this before. But it's an emergency, you control blood pressure, you intubate the patient, you give them seizure prevention, you send them, you call in the surgeon to take away the hematoma or get rid of the AVM or the aneurysm. Traumatic brain injury, you give them acetaminophen if they need it. Amantadine can be used to speed up their recovery. Brain tumor, what can you do as a clinician? You give them steroid to minimize the swelling and have the surgeon take care of the tumor. If they can't take the tumor out, they put a BP shunt. So they shunt, as the tumor grows and fills the cranium, they shunt CSF out to make room for the tumor. But just to help the patient live a couple of more months. That's all there is there. Pseudotumor cerebri, I told you to give acetazolamide because what you want to do is to block bicarbonate production. And once you block bicarbonate production, you decrease the formation of cerebrospinal fluid. Short of that, you do serial lumbar puncture. Okay? I think I'm done. Whew, that's a rough landing. Okay, I know you're tired. I have a couple of questions that I want to use to kind of just drive you home. You want to do them?
Yes.
Okay. My questions a lot. That is very encouraging. All right, let's see. So here is a 36-year-old female with no significant past medical history. Present with right-sided headache associated with difficulty chewing and clenching of the teeth. There is no associated visual symptom, nausea or vomiting. Physical examination and the initial laboratory test, including ESI, are unremarkable. Which of the following is the most likely diagnosis in this patient? TMJ arthritis. Thank you. This is not a headache. This is TMJ problem because it's a right-sided headache associated with difficulty chewing. What joint do you move when you chew? Your TMJ, and it hurts when she clenches her teeth. When in the world did you see trigeminal neuralgia? I mean, but you see that this is TMJ.
I was thinking that, but I thought it's headache.
Yeah, it's TMJ, right? Anybody think anything else?
No.
Eh? Well, if it is trigeminal neuralgia, your patient will have right-sided headache shooting towards the eyes, nose, and the mouth. Right? Right? No, that is constant. Right? And no visual symptoms, I mean, this TMJ. Right?
Yes.
Moving on. Let's match this. 79-year-old female with a history of polymyalgia and a right-sided headache and reduced visual acuity. What is that? Thank you. 29-year-old male student with a band-like non-pulsating headache. 35-year-old female with a unilateral left-sided pulsating headache associated with nausea and vomiting. Migraine.
Yeah, migraine.
Anybody think different?
Yeah.
40-year-old male executive with a right periorbital headache and partial ptosis.
Cluster.
68-year-old female, left-sided lancinating shooting, pain that shoots to the left eye and the jaw.
Trigeminal neuralgia.
Exactly, you got it. See, this is everything I've been talking about. This is where this. If you can just get this, this is how it comes into place. Which of the following is considered a high-risk factor in a patient with chronic headache? High risk. Talk to me then. Come on. What would make you worry in a patient with this?
Severe sudden
Thank you. Sudden severe onset. Thunderclap. Right? Thunderclap. Reversible cerebral vasoconstriction syndrome and subarachnoid hemorrhage. Right? Anything else?
You just gotta give us a chance.
You gotta give us time to read the choices.
Really read the questions.
Because very soon, Tia is going to tell me where's the problem. I think it's okay. All right. Let's do this one. Okay, I'll give you more time. 26.
Oh, God.
No. 26-year-old female with no significant past medical history presents with chronic daily headaches for 6 months. Headache is associated with double vision and clicking tinnitus. Patient has been on birth control pill. Do I still need to read more?
No.
What's the answer? Patient has been on birth control pills since her last confinement, childbirth, 3 years ago. Vital signs are unremarkable except for a BMI of 38. She's obese. Which of the following statement is false? You will never find a brain tumor on the MRI because this is pseudo tumor. Right? Excellent. How about this one? Let's match it. 60-year-old male alcoholic comatose. 6 hours after a fall inside the bathtub.
Regulator.
26-year-old female with the worst headache of her life. Thank you. 17-year-old male high school senior with headache, fever, and neck stiffness.
Meningitis.
56-year-old male hypertensive diabetic with headache and right-sided hemifacial paralysis. Intracerebral hemorrhage. There is no intracranial.
Oh, sorry, I meant cerebral.
Okay, everybody good with that?
Yeah.
68-year-old male smoker with vomiting and headache aggravated by coughing.
Brain tumor.
Good. You all know why that is the right answer?
Yeah.
Yeah.
Okay. Which of the following is considered a low risk factor in a patient with chronic daily headache? Low risk factor. Personal history of similar headaches. Good. What is the appropriate next step in the management of a 24-year-old baseball catcher brought in 2 hours after he was hit on the head by the batter? Patient passed out for about 10 minutes after the accident and has no symptom at the moment except for slight headache and a watery nasal discharge. There is no vomiting, no nausea. Physical examination is normal except for a fever of 1 or 2. What are you going to do?
Head CT.
Thank you. You will send it for HCT, you will give him as limited friend.
Give him a tetanus shot.
Yeah.
Excellent. All of them. Okay. Let's move on. This is now provided for something. 32-year-old female epileptic with a 6-year history of chronic migraine. What would you give them? Or give her? Topiramate, because topiramate is anticonvulsant. It will take care of the migraine and the seizures. 55-year-old female with a history of chronic tension headaches. Chronic tension headaches. She's stressing all the time. What will you do? Amitriptyline. Chronic tension headache. Amitriptyline. Right? How about this 48-year-old male hypertensive, recently diagnosed with chronic migraine? You will change his blood pressure medicine to metoprolol. That will take care of his migraine and his blood pressure. How about this 62-year-old male with a 3-month history of nighttime headaches that wake him up 4 to 6 times every night? Leave him on. How about this one, 40-year-old female hypertensive, recently diagnosed with cluster headache? Thank you. Thank you. You got it. Which of the following is not a sign of basal skull fracture in a patient with traumatic brain injury?
Hematocyst.
You don't. Somebody say hematuria? Hematocyst is not.
Yeah, hematocyst.
What about this? What is the most appropriate treatment in a 45-year-old male with a 6-week history of stabbing pain just above the right ear? There is no associated redness of the right eye, no tearing, no photophobia. Physical examination is significant for a small, well-circumscribed area of tenderness just above the right auricle. The pupils are equal, round, and reactive to light and accommodation. What are you going to give them? Gabapentin, exactly. Good. Let's match this. Orthostatic headache in the medicine. Reversible cerebral vasoconstriction. Temporal arthritis.
Prednisone.
Idiopathic intracranial hypertension. Vertebral artery dissection.
Verapamil.
Vertebral artery dissection.
Aspirin.
Aspirin. So what is this?
Verapamil.
Thank you. Reversible cerebral vasoconstriction. Calcium. All right. Which of the following statements about epidural hematoma is true? It is a venous bleed. Is it a venous bleed?
No.
Typically crosses suture line.
False.
It is an arterial bleed. That's it. See? 78-year-old female hypertensive diabetic with a history of alcohol abuse was brought to the emergency room by her daughter after she was found down like this. Vital signs are within normal limit except for blood pressure of 160/100. Patient is comatose. Glasgow coma scale is 6. Her neck is supple. The pupil is normal and reactive on the right, but dilated and fixed on the left. Patient withdraws all limbs from painful stimuli. Muscle tone, power, and reflexes are normal in all limbs. What is the most likely diagnosis? Let me help you figure out the clues here. First, one pupil is dilated and fixed, so it's a one-sided lesion, right? She withdraws all 4 limbs from painful stimuli, so she doesn't have paralysis. Right? Now let's go. Based on what we just said, it cannot be intracerebral hematoma, right? It cannot be subarachnoid hemorrhage because they said the neck is soft, right? So what is the answer? Subdural hematoma, right? Good, you did it. I just knew you would. Oh, yeah, no, it's done. Okay, let's wait a minute. Oh, okay. 23-year-old female, sudden onset headache and stiffness. We did this before, right?
No.
No? Oh, okay. You want to do it?
Yeah.
23-year-old female with sudden onset, severe headache and neck stiffness. 72-year-old male with right-sided head and jaw pain aggravated by chewing. 48-year-old female with repeated sudden severe headaches and negative head CT. Repeated sudden severe headaches with negative head CT. Reversible cerebral obstruction syndrome. 36-year-old obese female with generalized headache and cerebral palsy confusion. 40-year-old male smoker with a history of headaches associated with post-nasal drip and paranasal tenderness. Thank you. How about this? What is the most appropriate next step in the evaluation of a 56-year-old male hypertensive with a history of spinal arthritis who presents with daily generalized headaches, relieved by lying down and aggravated by standing up and heavy lifting? Patient was discharged from the ER 6 weeks ago following a high-speed head-on collision with a fire hydrant in his 2008 Chevy Suburban. Head CT and chest X-ray at that time were reportedly normal. What is going on there? Thank you. That person has hypotensive orthostatic headache, right? Low CSF pressure. The next thing you should do is not to repeat the CT. It's a bit longer puncture to establish the low CSF pressure, right?
Yes.
Good. Which of the following diagnosis is most consistent with this CT scan? Epidural. Thank you. Thank you. See, I knew that was. We did it. So now you guys are ready for my return. Remember CPA, trigeminal neuralgia and deafness.
Yes.
Don't forget.